What we're going to be doing is placing an implant in the molar area. Let's put it in number 14. And on a real patient, you'll either have a CT or radiographs to determine it, but we want you to have a feel for what it's like to use the equipment that we have. Our surgical kit is very nice, the Sybron surgical kit. It's very clean and neat and has a variety of drill sizes. If we start in the upper corner here, this is called a Lindemann burr, and that will be our first drill. It's very sharp. It also cuts on the edges, as we talked about during the program. We'll be placing a 4.1 diameter implant, actually a 4.8 by 4.1, meaning the head of the implant is 4.8 diameter and the body of the implant is 4.1. But we just make a stepwise progression in the drill. We're going to predetermine the depth of the implant using our radiographs and the tools that we gave you earlier. But during the Ladera Ranch program really helps us in determining exact position, meaning we're going to use radiographs to help determine our depth, where our vital anatomy is, and how wide or how long an implant we want to use. So let's go ahead and begin. So the first thing I'm going to do is take the Lindemann burr, and be careful with this one because it's relatively sharp, and we're going to simply, it's a latch type design, kind of rotate it in so that it stays in position. Now, on a real patient, you're going to use copious amounts of water, but in this situation, we won't use water, just for the sake of not making a big mess. Now, before I begin, I'd like to show you the motor that we're using for this technique, and if we can just kind of pan up a little bit. This is a Cavo system that's very, very nice. It's very versatile. You can use it in other applications other than endodontics. And you can see we have our measurements from 11 to 1200 RPM set at 55 Newton centimeters of torque, and it's a 27-to-1 reduction. When we're placing the implant, we'll use copious amounts of water. You can see the number 4. And during the hands-on, we'll demonstrate how this handpiece works. But we have a foot control that allows us to very easily change the position so that when we want to place the implants, we can put it in at 35 revolutions per minute at 25 Newton centimeters, which means that implant, the motor or the handpiece will actually stop when the implant is placed at 25 Newton centimeters. And anything more than that, if we need to go deeper, we can hand tighten that into position. But it's all foot controlled, very easy to monitor, to control. But let's go back to our surgical procedure. So we're going to be drilling at 1200 RPMs with copious amounts of water. Well, let me turn that water off in this situation. And you can see that just switched to 0. So we come back to our model. We have a maxillary area, and we're going to place our implants. I'm going to be working backwards here, and I apologize for that, in the number 14 area. So the first thing we want to do is we want to place the implant in the correct position. We know that we want it to be at least 2 millimeters from an adjacent natural tooth. The implant should be about 3 millimeters apart from each other. But in a situation like this where we clearly have a wide ridge, good buccal lingual and mesial distal width, we pretty much want to put it in the center of the bone. Now remember, this drill is very sharp, and we'll kind of do this together, or we can show it on the video. So we want to make sure that let's do it this way, so that we're kind of in the center of the ridge and good buccal lingual dimension, pretty much straight up and down where we want to be. Now we can check this radiographically quite easily, and we're going to go to about 7 millimeters with this burr. Now I didn't show you the depth of these, but these burrs, if we can get a close-up of the burr, could we do that? Are clearly marked with black lines, and I'll just kind of position this. The bottom of the first black line from the tip is 7 millimeters. The top of that first heavy black line is 9 millimeters. Then there's a second heavy black line. The bottom of that heavy black line is 9, the top is 11, and then to the hub of the burr is 15 millimeters. So what we'll do with our lindemann in a patient is you'll go to about 7 millimeters or so and determine if we are in good angulation, good ridge contour. But the best thing to do at this point is to go ahead and take a digital radiograph and know exactly where we are. If we're not in the exact position that you want to be in, it's okay. We can reposition it. We can move it in different directions, buccal, lingual, mesial, distal, until we're completely happy with it. Once we decide that we're happy with that, we're going to go to a 2.2 twist drill. And again, you can see the clear markings, the two heavy black lines. So the markings are 7, 9, 11, 13, and 15 to the hub. And again, we're going to follow the position of the lindemann, and we're going to go just a little bit deeper here, and we can stop and take a radiograph at that point also. So it looks good, but we can radiographically determine if it is in the right position. Now we have tissue height here that can be a problem. And what we are going to do is to punch that tissue or remove the tissue around our initial osteotomy site. Now, how do we do that, and why would we do this? Well, this is a flapless procedure. We pretty much know that we have great bone to work with. So here I'm using a simple tissue punch that will provide you today. There are tissue punches that can be added to your handpiece that you can use. But for the sake of argument, I'm just going right in the middle of my initial osteotomy site on a patient. That patient may bleed a little bit. And I'm pushing down and see if we can remove that little bit of tissue from that area. Nice, clean. And that's pretty much what it looks like in a real patient too. Nice, clean incision. And what you'll have is a tissue plug in the patient that you'll discard. Now the advantage that we have at this juncture is we can see the bone to some degree depending on the thickness of that tissue. And it looks like this tissue is about 3 millimeters deep. There's a lot of tissue. So in our case here, we're providing you 11 millimeter long implants. So if we assume that the tissue is 3 millimeters in this situation, and we want the implant to be buried 11 millimeters into bone, our measurement will then be 11 plus 3, which is 14 millimeters. So we're going to use our drill again, and remember what we said, the markings are 7, 9, 11, 13, 15. We're using an 11 millimeter long implant, 3 millimeters of tissue height. So we're going to nearly go to the hub of the implant, a millimeter short of the hub of the drill. I'm sorry. We're going to go a millimeter short of the hub of the drill at the tissue height because we can't really see the bone completely. We can see it a little bit, but not completely. So let's go ahead and take our 2.2 twist drill, and I'm going to go nearly, you can see that nearly to the hub. Now at this juncture, take the twist drill off of the handpiece, place it in the patient's mouth, and go ahead and stop and take a radiograph to make sure that you're in the right position. Now one of the wonderful things about the Ladera teaching program is you can really stop at any time. If you don't feel comfortable progressing in a larger size drill, or if you feel that you've perforated the sinus or you're too close to the nerve, it's okay to stop. You've made a very, very small opening in the bone. It will heal, and certainly the patients will understand. Now we're going to our second twist drill size, which is 2.8, and this is the drill used for the 3.3 diameter implant. So our drills are a little bit smaller in diameter than the final implant. But here's the 2.8 twist drill, and again the markings are very clear. And if we're in correct position radiographically, the procedure gets very, very simple at this point. About 14 millimeters into the tissue, stop, and again stop and take a radiograph. Make sure you're in the right position, knowing that you can stop at any time. Now we'll go to the 3.5 diameter twist drill, which is used for the 4.1 implant, which we predetermined we're going to use here. And again, these drills are very sharp, and you're just going to follow along without any issues whatsoever. Very quick at this juncture. Now the implant, the dummy implant that was provided me is a octagon shaped, and it's 4.8 at the crest. That is a wonderful implant to use, especially in the molar area and the maxilla, because it's wider and you don't have to worry about pushing the implant into the sinus. But because it's a little bit wider at the neck, you may want to use the profiler, which is a drill that flares at the crest. So I'm just going to do this to demonstrate, and you're just opening that up a little bit. Well, we're done drilling. We've taken our radiographs. We know we're in ideal position. Every case that you do is in an ideal situation. So what you want to do at this point is see your implant. Now this is a dummy implant that you'll use, and you can see it's very clear. It's a 4.8 octagon, meaning it's 4.8 diameters at the neck, but the body is a 4.1 and it's 11 millimeters long. You want to make sure you work with your staff. Don't open these implants until you're absolutely sure you have what you need. There's dual packaging, and again, very easy to demonstrate. Sybron Pro XRT 4.8 octagon, 4.1 by 11 millimeters. This packaging rips open, and again, very, very clearly marked. Now what you do is you just break this open, and you can see the implant in position. The other thing that I'll demonstrate here before we move on is inside this cap there is normally a cover screw, which is a flat screw, which is comes with the implant body, so you don't have to buy an extra one. Depending on how much torque we can place the implant in will determine which type of threaded screw you will put into the implant. If it's less than 25 Newton centimeters, meaning the bone is soft, then I would suggest that you put in a cover screw, a flat screw. If it's greater than 25 Newton centimeters of torque, the implant is torqued greater than 25 Newton centimeters, then we can put a healing abutment, which is a taller screwed in appliance that allows the tissue to form around it, and we'll demonstrate that in a few moments. Pretty straightforward. If you're able to torque the implant to 35 Newton centimeters, then theoretically you could load the implant right away and put a tooth on. I'm not a big believer in immediate loading, but it's certainly something that we can demonstrate. And if we could pan back up to the drill system. Well, what we're going to do is now switch, very, very important that we switch our handpiece to, it says 11 to 35, no water, and at 25 Newton centimeters of torque. That's the important number, 25 Newton centimeters of torque. And what we're going to do is now, we're going to go ahead and put it in a handpiece, and we can come back. And you're going to see how slowly that rotates. And it will theoretically stop at 25 Newton centimeters of torque. So we have our implant and we have our tool. and we're simply going to lock it into position. Now be very careful when you're going to the mouth. You kind of want to hold it upside down, and we'll come back to the mouth and place the implant very, very, very slowly. Now we can stop pretty much at any time. If you want to, you can stop. And we can see that we're not quite deep enough. And we can go to our hand torque. Or hand ratchet. And this is an excellent tool. We'll demonstrate it very clearly. There's markings on it. You can see 3 lines and a little spring arm here. The first line is 15 Newton centimeters, and then 25, and way out here that third line is 35 Newton centimeters. So as I said earlier, depending on how tight the implant goes into the bone, and it'll all depend on the quality of bone, will dictate how or what you can do as far as loading the implant. You can see a little arrow here. That arrow is facing towards the spring ball. And if you wanted to reverse an implant, you simply pull that out and flip it around. I know it's kind of hard to demonstrate that, but you can see now the arrow is going in the opposite direction. But here we want to torque it into position, so we're going to have the arrow pointing forward. We're going to take again our implant driver for the 4.8, and it just snaps into position. We'll go to site, and we're simply ratcheting the implant into place. And these models are very, very soft. Let's see where we are. I think we want to go a little bit deeper. And this, again, these models are very soft, so we may not even get to 15 Newton centimeters. But we can see the implant's in position. Now I would strongly recommend that you go ahead and take a radiograph. Make sure you're in the right position, you're at crestal bone or slightly above crestal bone, depending on your preference, and that you're away from any anatomy. So the last thing I want to demonstrate is the placement of a healing abutment. And as I said, you can put a flat screw, a cover screw, or a healing abutment, and you can see this is a little bit taller. And it'll allow the tissue just to form a cuff around that implant, so that the implant itself doesn't bury, and you don't have to do a secondary surgery. So we'll be working with this in a few minutes, and you'll get a feel for what it's like to place an implant on a model. Okay, so now let's look at the prosthetic components that we're going to do during our hands-on demonstration. This is the box that you're going to get. Be careful, the parts are really small, and we want to make sure that we return everything that we have. But you see a lot of components there. I won't be able to flip it over. But you also see the pictures. And let's just go through these one by one. First thing we have on the upper left side are healing abutments and cover screws. In the lower right we have a little hex tool that I want you to grab. And then let's look at the 3 different types of screws that we have. We have first the cover screw, which is a flat screw, and let's just demonstrate that very quickly. This will just take us a few moments. And if you go to one of the implants, get a little closer there. Good. And you simply place the hex tool, and the implant is basically buried. We said earlier You'll use this if you get less than 25 Newton centimeters of torque. So there's no pressure on the implant at all. Now let's go to a platform switching healing abutment. This one is about 2 millimeters tall. And platform switching means that the margin is on the outside. We don't impinge on the tissue on the outside at all. So this abutment, if you can get closer, please, is actually inside the body of the implant as opposed to, there you go, you can kind of see there's a little triangle in this area here, a little catch there. But in some situations, and if you're used to more standard type of implants than this modern technology, you could use a healing abutment that does extend onto the outside margin of the implant. And you can see there's no little triangle there. And we'll talk about, or we have talked about, the advantages and disadvantages of platform switching. So you'll play with that a little bit. Now let's look at our impression techniques that we have. And there's two different impression techniques in implant dentistry that we'll go through. One is a direct impression where you have an impression coping. There's a screw on the inside, and it will engage the hex inside the implant. And again, this is platform switch, so it's on the inside. Has a flat edge. You can see that flat edge. And so when you take this off, eventually, you want to make sure that you're very conscious of where that flat edge is so that you can put in the impression the same way. The other technique is a open tray technique, where again you have a different type of impression design and a floating screw. That floating screw has to be threaded in, and then it locks into position. And again, you simply line it into the implant, tighten it. Here you would do a cutout of your impression tray and let the material harden, and then simply unthread this screw. When you take out the impression, the impression coping will come out with the impression. In the back impression design, it's a direct impression. The impression is removed, then you have to simply remove this impression coping. And then take it to an analog. An analog is a duplication of what's in the patient's mouth, and you have to duplicate that hex design or octagon design. So we'll simply thread that in, and remember we talked about the little flat end, and this will just go back into the impression precisely. Now you can let your laboratory technician do that, or if you feel comfortable doing it, place it in the impression and you're ready to go. The other things in these kits are the different abutment types, and there are a variety of abutments. The first one that you see there is a straight abutment, and this is basically what a dental laboratory would use. You can provide it to your laboratory, and I recommend that you do, but it's an abutment, a straight abutment. It's not platform switch, meaning it covers the outside edge of the implant. And the laboratory can prepare this. They can prepare a margin, they can shorten it and do whatever they need to do. Can you get a little closer there, please? And go ahead and leave it closer. There you go. So this abutment can be prepared. The middle tray is a premier platformed switched abutment, similar to what we just demonstrated, but we don't engage the outer edge of the implant. Now I prefer the platform switching. I think it's less invasive for the patient. There's no impinging of the tissue, and you certainly don't need anesthesia. So you can see that the laboratory again can prepare this abutment for length and even a margin to some degree, and you're all set. There's two other designs that are in this kit that we'll just demonstrate very quickly. And that's the direct platform switched abutment, and this again has a special tool, and what you're doing here is kind of saving a step. If your implants are ideal and you don't have any problems, you can put this abutment in. It engages the hex and temporize it with this little cap here. Obviously this is tall here, but you can cement that little cap in position and let the patient go. And you could take an impression at that point, or go ahead and put a temporary type of crown on there. And finally, there's a solid abutment that again is you know, similar. These again, the last two do not engage the hex, so you could use this when you have multiple units and go ahead and put a temporary on the implant immediately and cement that in. So the last two, the direct PS abutment and the solid abutment, do not engage the hex, so they can be used for multiple units very predictably. I wouldn't necessarily use them for single units. The UCLA is a very typical, there's a plastic component here, it engages into the impression, and then the laboratory can make a custom abutment, can cast or scan for a zirconia abutment without any problems. So why don't we play with that for a little bit? Let's make sure we put all the tools back into position, and then we'll do a little go to the next step. All right, let's just do some bone grafting now. Here we have a model that has a socket site, and what we're going to do is we're going to use this non-sterile beta tricalcium phosphate. There's different particle sizes. I prefer the 500 to 1000. We'll put it in a sterile dish. And what you want to do with this is mix it with blood, and we have some fake blood. So we're gonna grab some blood from the patient. And you don't want to use sterile water necessarily. Sometimes you can't help it, but what the water does is surrounds the particles, and you don't get quite as fast of regenerative properties. So you do want to mix it with blood. Now if you don't have a lot of blood, then carrying it to the site, maybe wet it a little bit and carry it to the site will work very, very well for you. So what I did was I poured some of the beta tricalcium phosphate and mixed it with some fake blood. And then we're simply going to go to the site, and just to get a feel of what it's like wet sand almost. And we'll go ahead and we'll fill this socket. Just kind of, you don't want to crush the particles, but you do want to be firm. You want to use firm pressure so that the entire socket is filled. And what's nice about this, as we've demonstrated in the program, or will demonstrate in the program, is you can definitely see changes that occur as the bone matures. So just get a feel for what that's like. You fill the socket. And then when you're augmenting, when you're putting synthetic material in place, you want to use a barrier, and this is a resorbable barrier that will be sutured into position. And you want to wet it, and when you wet it, it does give you a little bit more manageability. And it's a little bit difficult to do on a model, but you get the idea. We'll tuck that underneath the tissue. But one of the tricks that we learned was suturing, and I'm just going to show you a quick suturing technique. It's just a cross pattern on the buckle coming through. Now you can see I don't have a barrier in place yet. Pull it through, and this is the Cytoplast Teflon suture, which is just wonderful to work with. It's non-resorbable. And then we'll go to the lingual and we'll do the same thing, starting on the mesial, going to the distal. And I just want to show you a little trick here, what we're able to accomplish. You can see we're going to get a cross stitch. So if we come back and place our barrier, I'm not going to play with this too much, but you get the idea of tucking it into position to prevent invagination of soft tissue and get real fancy there. But with our cross stitch, what we're able to do is simply lock that material in place with a cross stitch. Okay, so let's try that.